Dear students, this class is on risk assessment. I am Dr. Rajkumar, head of the Department of Periodontology. So we'll go on to today's class. So the learning outcomes for this class is categorize various risk assessment, list 3 risk factors, explain in detail about various risk assessments, use these assessments during the treatment. Coming on to introduction. Prognosis is an essential part of periodontal care and it influences the treatment planning considerably. So when we are thinking about prognosis, risk assessment is an important factor to evaluate the reliability of prognosis. When you want to do a prognosis for a patient, there should be a risk assessment which will help you to get to a reliable prognosis. From a clinical point of view, the stability of periodontal condition reflects a dynamic equilibrium between the bacterial challenge and an effective host response. Whenever there is a change occurs in either of these aspects, homeostasis is disturbed. Hence, it is evident that the diagnostic process must be based on the continuous monitoring of the multi-level risk factors. So you have to evaluate the risk status of the patient on every visit. That is what we are trying to say. The risk factor and risk assessment is an important factor in periodontal treatment. When you do a proper risk assessment, then you can able to do a proper treatment for the patient. So coming on to the risk assessment. What is risk? It is the probability that an individual will get a specific disease in a specific period of time. So the risk is further subdivided into risk factor, risk determinant, risk indicators, and risk markers or risk predictors. We'll see one by one what it is. So risk factors may be an environmental factor, may be an behavioral factor, or a biological factor that when present increase the likelihood of that individual to get a disease. It can have increased the likelihood, but it is not mandatory that it should induce the disease, but it will increase the likelihood of the person getting the disease. So the risk determinant is most of the time substituted with risk factor, but it should be reserved for the term risk determinant is reserved for the factors which cannot be modified. For example, age. You cannot modify the age of a patient. So those are risk determinants which cannot be modified. The risk factors which cannot be modified should be called as risk determinants. Next is risk indicator. Risk indicators are probable or putative risk factor that have been identified in cross-sectional studies but not confirmed through longitudinal studies. For example, HIV. HIV has shown to have a frequency of in periodontal disease, but we don't have a longitudinal study to state that HIV will induce periodontal disease. That is what risk indicators. So presence of that disease have the probability of getting periodontal disease. Risk predictors or risk markers. These are factors which are although associated with increased risk for the disease, but it will not initiate the disease or cause the disease. So for example, bleeding on probing. So when there is no bleeding on probing, it doesn't mean that the patient is free of disease. But whenever there is bleeding on probing, it is a good indicator that there is a disease present. Right? That is what risk markers are. These markers will help in identifying the disease. We'll see individually what is the risk assessment, what are all the factors involved in. So risk factors may be environmental, behavioral or biological factor. When present, increase the likelihood that an individual will get the disease. So the examples are smoking. Smoking is one of the environmental factor which is an well established environmental factor or a risk factor for periodontal disease. Smokers or current smokers will have more periodontal disease, chance of getting a periodontal disease compared to a non-smoker. Next is diabetes. Diabetes is again a clear risk factor for periodontitis. Levels of diabetic control is an important variable in relating periodontal disease and diabetes. So whenever there is an uncontrolled diabetic, there is high risk of increased in periodontitis status. The severity of periodontitis increases as the diabetes level increases. The vice versa goes on. When there is a well controlled periodontal disease, the diabetic level goes down. So a well maintained periodontitis patient will have a controlled diabetic, and well controlled diabetic patient will have a controlled periodontal disease. Next is pathogenic bacteria. The quality of the plaque is not the major importance in the disease process, but some type of organisms present in the plaque will definitely induce disease. For example, red complex organisms like Phorphoramonas gingivalis, Prevotella intermedia, Tenerella forsythia. So these are often found in chronic periodontitis. Cricetibacter actinomycetum committens is associated with aggressive periodontitis. So these pathogenic bacteria have association with periodontal disease. So whenever there is a presence of these microorganisms, there is possibility of getting that periodontal disease. Next is microbial tooth deposits. Calculus is one of the reservoir for bacterial plaque to accumulate onto the tooth surface, which is suggested as a risk factor for periodontitis. But mere presence of calculus will not induce periodontal disease. It is the plaque which accumulate over the calculus which is going to induce the periodontal disease. So next variable is the risk determinant, those risk factors which cannot be modified. Examples are genetic factor, age, gender, socioeconomic status, and stress. Genetic factor, a specific type of interleukin, for example interleukin 1 genotype, has been associated with severe chronic periodontitis. Age, both the prevalence and severity of periodontal disease increases with age. Younger individuals with periodontal disease may be at a greater risk for continued disease as they grow older. When it comes to gender, males have poorer oral hygiene compared to females, and males have more loss of attachment than females. Prevalence of severity of periodontitis are related to the preventive practice rather than the genetic factors. Socioeconomic status, again, it decreases the dental awareness of the patient and decreases the frequency of dental visit, which is again a risk factor for getting a disease. The final part is the stress. Either an emotional stress may be interfere with normal immune function, which results in increased levels of circulating hormones. These circulating hormones which results in more amount of pathogenic bacteria to grow, which will eventually result in disease formation. Next is risk indicator. These are probably or putative risk factors that have been identified in cross-sectional studies but not confirmed through the longitudinal studies. I have given the example of HIV, which increase the susceptibility of getting periodontal disease. Next is osteoporosis. Another example is an osteoporosis, where the reduced bone mass seen in osteoporosis may aggravate periodontal disease progression. Third example is an infrequent dental visit. When the patient is not following the dental visit in a regular intervals, there are more risk of getting disease. Longer the interval between the dental visits, higher the chance of getting the disease. The final part of risk assessment is the risk markers. which are associated with increased risk for disease but do not cause the disease. Example, previous history of dental visit, which is going to help us a good clinical predictor for risk for future disease. If the patient have a good previous dental visit histories, then the patient may have a better complaints for the future visits, which will provide us a good prognosis for the maintenance for that patient. The greater risk for future loss of attachment if the patient doesn't follow or have a proper previous dental visits. Another risk marker is bleeding on probing. This I have already told, which is a best clinical indicator for gingival inflammation. Bleeding on probing coupled with probing pocket depth may serve as an excellent predictor for future loss of attachment. So this is all about risk and risk assessment. So we have talked about what are all the various factors involved in risk assessment. What is risk factor, what is risk determinant, what is risk indicator, what is risk marker. Now we'll go on to how to evaluate the risk. How we are going to evaluate the risk. So when it comes to risk assessment, we are going to follow a risk assessment chart. So periodontal risk assessment chart, it is a functional diagram which was proposed by Dr. Lang and Tonetti. So this comprises of various factors which is going to help us in predicting the risk of periodontal disease for those patients. For example, it consists of 6 factors, which is bleeding on probing, probing pocket depth, tooth loss, bone loss, systemic and genetic disorders, and environmental factor. Let's see how it is going to help us in getting the risk assessment. So basically they divided this into 6, and the 6 is further divided into various subcategories. For example, the bleeding on probing. Bleeding on probing values, whether it is 4, 9, 16, 25, 36, more than or equal to 50. Same like that, probing pocket depth, 2 mm, 4 mm, 6 mm, 8 mm, 10 mm, 12 mm. Tooth loss, number of tooth loss, tooth 4, 6, 8, 10, 12. Bone loss, 0.25 mm, 0.5 mm, 0.75 mm, 1 mm, 1.2 mm, and 1.5 mm. Systemic disease, whether it is present or absent. Environmental factor, whether the patient is having a habit of smoking, whether it is a non-smoker, former smoker, smokes less than 10 cigarettes per day, smokes more than 10 or more than 20. That determines the environmental factor. So how to assess the status of the risk using this chart? So when the chart is filled, if you see more than one factor in moderate, that means 2 factor in moderate category, then it is a moderate risk. If only one factor in moderate category and all the other factors in low category, then the patient falls under low risk. So to call a patient as low risk, either all the 6 factors should be inside the low risk, or one factor can be at moderate risk with all the other factors in the low risk. Then the patient is called as low risk patient. When it comes to moderate risk, more than one factor, that is 2 factors in moderate risk, and not more than one factor in high risk category, is considered as moderate risk patient. If factors more than 2 factors in high risk, then the patient is considered as high risk patient. So you can read about your periodontal risk assessment in this following book, Oral Health and Preventive Dentistry book, which was given by Dr. Lang and Tonetti. If you want to learn it online, you have tools to learn periodontal risk assessment online with the help of the links provided here. So when to do risk assessment? So when the patient comes to the clinic, you have to get the medical history, dental history, periodontal examination, and you have to assess the risk. Once you do the periodontal examination, then you have to assess the risk. After assessing the risk and giving the prognosis, do the primary treatment, phase 1 treatment, then evaluate the response to the phase 1 treatment. If the response is positive, then your risk assessment is correct. Then you can put the patient under maintenance. If your response to the phase 1 therapy is negative, then you have to go back and reassess the risk. You have to do the risk assessment again to evaluate what went wrong, and your prognosis changes. Then you have to again go into your non-surgical periodontal therapy. Again see the review whether it responded or not. If it responds, then put the patient under maintenance. If it doesn't respond, again you have to re-evaluate the risk factors. So this is how you are going to assess the risk factors. So coming on to the evaluation of your periodontal risk assessment, how we are going to do the evaluation. So you have to fill up all these things. So after you do the periodontal examination and periodontal charting, you will get most of the values from the case sheet. For example, bleeding and probing, you are going to take the modified sulcus bleeding index, which is going to help you in identify the bleeding score, number of tooth which bleeds, or number of sites which is going to bleed. Then you are going to evaluate periodontal index, Russell's periodontal index, and your periodontal charting, which will give you the probing depth, how much is the probing depth, and your periodontal charting will give you the number of tooth lost. Periodontal charting will help you in getting the bone loss with the evaluation of clinical attachment level. So you are going to evaluate the clinical attachment level in your periodontal charting, which you can evaluate the bone loss happened in that patient. Systemic and genetic factors and environmental factors should be taken from the history part of the case sheet. So with all this data, you are going to evaluate the periodontal risk assessment. So basically you have to fill this and evaluate whether the patient falls under low risk, moderate risk, or high risk category. So these are all things you are going to evaluate. So age, number of teeth or implant present, number of sites per tooth, number of tooth with bleeding on probing, or number of sites with bleeding on probing, number of sites with probing pocket depth, number of missing tooth, percentage of alveolar bone, systemic or genetic factors, and environmental factor. All these things we have to evaluate to come do a risk assessment. So when you complete the risk assessment, the chart will be something like this. Either all the factors in a low risk category, which will comes into low risk, or one factor may be in moderate risk with all the other factors under low risk, still it is called as low risk patient. So when more than one factor goes into moderate risk, then it is patient goes to a medium risk category or moderate risk category, more than one factor. So if there is 2 factors out of 6 is in moderate, then it is moderate risk patient. Again, not more than one factor in high risk. The patient can go with one factor in high risk with all the other factors either in moderate risk or in low risk. With 2 factors in moderate risk, still the patient is considered as moderate risk or medium risk patient. So high risk patient, more than one factor in high risk category, the patient is considered as high risk patient. So based on this, you are going to come to the prognosis and you are going to suggest the recall intervals for the patient. For example, if you are going to go for a low risk patient, your recall interval will be longer, either 6 months once or 12 months once. When you are going for a moderate risk or medium risk patient, then your frequency of intervals will be 6 months or less than 6 months. And if the patient is a high risk patient, your recall interval should be 3 months or less than 3 months interval. So you have to, the frequency of recall should increase as the risk status increases. Higher the risk, higher the frequency of recall should be there, so that you can prevent the occurrence of periodontal disease in such patients. So to conclude, risk assessments involves identifying elements that either may predispose a patient to developing a periodontal disease or may influence the progression of disease that already exists. In either of these cases, these patients may require modifications of their prognosis and their treatment plan. In addition to evaluating patients, the patient should be educated about the risk, and when appropriate, suitable intervention strategies should be implemented. So the patient with a high risk profile after active periodontal therapy were more prone to recurrence of periodontitis and greater tooth loss during supportive periodontal therapy rather than the patients with moderate or low risk profile. So our frequency of recall visits should increase as the risk profile increases. That is what we have to do. So it is mandatory for you people to take periodontal charting and risk assessment evaluation when you are taking a periodontitis case sheet in your oral medicine department. Okay, thank you.